talking. This is the team part of the two talks, but I'll be talking a little bit about mathematical modelling, statistical modelling. If you don't understand anything, just let your eyes glaze over and then ask lots of questions afterwards. So, why do we want to forecast epidemics? If you think back 10 years ago, we had the SARS outbreak. And when people think back about SARS, you think, oh, it was a terrible thing, so many people died. Actually, very few people died of SARS. I don't want to belittle the impact of that, but more people die of flu or HIV every year in Singapore than died of SARS in 2003. However, it caused a massive damage to the economy. About $5 billion, or 1% of GDP of that year, was knocked off. And it required a very large response from the government. So thousands of people were isolated at home. Thousands of people were put under surveillance. If you think back to 2009, in more recent memory, the government again used lots of quite strict control measures to try to control the pandemic. And it's important to be able to decide how long should they be, which control measures should they use and for how long should they be using them. Dengue every year costs about $100 million of damage. Some of it is control measures by EHI, some of EHD, and some of it is the impact on lost productivity, hospitalizations, and so on. A typical week will see between 100 and 200 infections, and a substantial proportion of them will be hospitalized. I've been hospitalized with dengue, and it was not nice. It cost me quite a lot. So we want to be able to work out what interventions we should be using. During the current dengue outbreak, the National Environment Agency has been hiring people on temporary contracts in order to try to bring the outbreak under control. I've seen ads in the newspaper. In order to decide whether you want to do that, you have to know something about what it's going to be like in the future. So I'll be talking about two forecasts that I've done. One on pandemic influenza, laser is this one, and one on dengue. This one with dengue is working with Li Ching and colleagues. On pandemic influenza is working with colleagues from the School of Public Health. Now, whenever we're thinking about forecasting the future, we should always remember the deep philosophical words of Yogi Berra. Prediction of the future is very difficult, but it's often done if you think about the weather. If you look on the news or you read in the newspaper, you will see people are forecasting the weather all the time. Why are people able to forecast the weather well, and can we use the same techniques for infectious diseases? When people forecast the weather, essentially they're bringing together two different sources of information: expert knowledge about the drivers of the environment and data on the current weather system. Now, the difficulty is that with infectious diseases, we have much poorer quality data than people who are looking at the weather have. So there's two approaches that we can try to use: what I'm calling a clever approach and a dumb approach. So we'll start with the clever approach. Here, we use our expert knowledge about the drivers of infectious diseases. We come up with a biological model, represented mathematically, but it's representing our biological knowledge. And this is something like describing the physics of the system. One person is infected by a mosquito. That mosquito goes along and infects someone else. We know something about how long mosquitoes live for. We know something about the infectious period in people. And so that lets us build a model, a biological model. The challenge really here is that the models are quite complex, so synthesizing them with real-time data is very difficult. The dumber approach, that's Jim Carrey. I'm sure he's a very intelligent guy. It's more statistical. Basically, it's like taking a large data set and looking for patterns in this, looking for patterns that could be replicated in the future. The challenge here is to have good enough data and have enough of that data in order for those patterns to be able to extrapolate. So let's look at them in turn. The mechanistic approach is the approach that we used when we were forecasting the pandemic in 2009. So we'll talk about flu first. Here is a timeline of pandemic influenza in Singapore. In grey, we have government polyclinic data. So this is, these cover about 20% of the population, and these are people who are the count of the people each week who have symptoms of a flu or of a cold. Cannot quite distinguish which. If you look at this time, we have something like 15,000 cases a week in the polyclinics. Not all of these are influenza. A large fraction of them will be things like rhinovirus or adenovirus. We have a school holiday here, then we have a pandemic, then we got back down to normal again after that. The coloured lines indicate Google searches, but really just indicate more the events that were happening which were making people interested in flu. There was a WHO alert in April. The first importation in May. I was in the Ministry of Health at the time of the first importation. We were having a meeting about it, and suddenly everyone from MOH disappeared. They got a phone call and they said, okay, sorry, we're going to leave you guys now, and we were all just left sitting there wondering what to do. The first unlinked case happened around the end of June, and then we started to see localized transmission. Vaccine came only in the market in October. What we wanted to be able to do here was to know when should we step down the control measures that we were going to be implementing. Control measures included screening in hospitals and schools. They included isolation of people who were known to have had a contact with someone, and quarantine of people coming into the country from Mexico. So we wanted to see when should we step down these control measures, and when should we implement other research studies which required knowing the end of the epidemic. So we teamed up with Goli Gan from the College of Family Physicians, and we set up a surveillance network where doctors would send fax or an email to Jimmy in Tan Tock Seng every day, saying how many patients they had seen with something that looked like influenza. And that's what I'll show you in the next slide. You can see how the number of influenza-like illnesses per GP rose and fell down as the epidemic progressed. It's a bit messy because we only were able to recruit about 20 GPs because Singapore GPs are very busy and a bit kiasu. But the 20 that took part were fantastic. We depended a lot on them. You can see there's different colours here. This is the weekend. There's far fewer people go to their GP for a sick note of the weekend. You'll also notice then that far fewer go on a Friday than go on a Monday. Pattern which is reproduced in Singapore Armed Forces. Far more soldiers need medical notes on a Monday than a Friday. I don't know. So, how do we try to... This is just what we got after the end of the epidemic, but we're getting data in every day. We wanted to be able to forecast what it was going to happen after that. So the approach that we took was to represent the system with a mathematical formulation, representing our knowledge of the biology of spread. So we assume that everyone belongs in one of these categories and they move along in this direction with time. So people start off susceptible, they become exposed by being sneezed on or coughed on, infectious, and then most of them will recover, some may die. And we're linking this down to data here. So some of those who are infectious will go to see their doctor, some of them will go to our doctor, and therefore will be entered into Jimmy's data set in Tan Tock Seng. But also some people who don't have H1N1 infections will go to our doctors, and that will cause a bit of problem. So we represent this mathematically. This is the only set of equations I'm going to show you, because I don't expect you to understand them, it's a bit difficult. But there's two things I want to point out. These two things here. The number of people who are visiting their doctors and the number of doctors sending a fax every day. These are the only two things that we know. We don't know any of the other mathematical things there. So we have to try to estimate them. The way that we do this is to simulate this model and then see how close it is to our data set, and simulations which are close to the data set are good, those which are far away are bad, and we use that to create the forecasts. So I'm going to try to show you those forecasts. So my technical skills are not very good. I got one of the videos into the slides, but not this one. We'll let it run through a couple of times, so I need to talk about it. In red, we have the data that we have collected so far. In orange is the future data. We are combining two sources of information here. We're combining the sources from our local sentinels with information from Mexico. I don't know if you remember the news towards the beginning of the epidemic. There was a lot of panic. The data from Mexico was saying that this was going to be a very severe epidemic, and that's represented in the early forecasts. So when we go back to the beginning, you'll see we're forecasting a very, very large outbreak in Singapore. The black and grey bits are our predictions. The black is bit is the bit that we think is most likely, the grayer bits are things we think are less likely. So at the very beginning we have very little local data, and so we're relying only on the Mexican data, which said everything's going to be really terrible. By about the middle of July, we're forecasting that things were going to get they weren't going to be as bad as we thought, and that the peak would occur somewhere towards the end of July, middle of August, start of August. We forecasted down very well. Forecasted up, not quite so well. But we didn't have very good data going up. Okay, so let me talk about how we're doing the forecasting with on dengue with EHI just now. This is how it spreads. So, our approach is that I'm going to try to describe some stats here with pictures. Stats with pictures. We have here data, which we have seen already. This is what we wanted to forecast. We're going to create something which looks like a single model, but it's actually not a single model. It's a collection of models. Make a separate model for forecasting 1 week ahead than from forecasting 2 weeks ahead or 3 or 4. Each of these is built in isolation of the others. And that makes things much easier, because essentially then all we're trying to do is to forecast one thing, not to forecast a lot of things. So let's look at trying to forecast 3 weeks into the future. So then we have, going back in time, we went back maybe 2006, I believe, and we have the number of cases every week in a vector like this, and then we collect lots and lots of data sets that might be relevant for creating this prediction. So here we have the number of dengue cases this week. So this would be end of 2012. We're forecasting 3 weeks into 2013. And we're taking the number of dengue cases this week in end of 2012. 1 week before that is what's being used to forecast 2 weeks into 2013. But we also allow that 1 week beforehand to forecast 3 weeks in 2013. This is not making much sense, is it? It's not even making sense as it comes out of my mouth. This is the same number. We're using the same numbers twice, but for different forecasts. Does that make more sense? One guy thinks it makes sense. Thanks. Then, to create this forecast for 3 weeks into the future, what we're doing is we're taking subsets of this data set, and we're using those to make the forecast. So the difficulty then is, what subsets of the data should we use to make the forecast? And we'll be using different subsets for different weeks. So if we're forecasting 1 month into the future or 3 months into the future, we will use different sets of the data. They really are separate models. What are we putting into these? We're putting dengue incidence going back several months. We're putting temperature, weekly mean temperature, weekly maximum temperature. We're putting humidity, absolute and relative. The breeding percentage, the fraction or the ratio of Egypti to albopictus, which is given that Egypti is the main vector for dengue, that's important. Seasonal trends and population sizes and other things. How complex should the model be? If we put almost nothing into our model, we have a very, very small model, then we will underfit. For the data we are trying it out on, we're going to get a poor fit to that, and we'll have low predictive accuracy when you go into the future. If we put everything into the model, then we will be overfitting. We'll have a very good fit in the past, but we'll have low accuracy in the future because we have over-specialized in the past data. Somewhere in between is the Goldilocks spot. It's not too hot, not too cold, not too big, not too small. We get a good fit in the past compared to a very good fit with this, but we have higher accuracy because we are taking the most important predictors only. And we're using a statistical approach called Lasso. It's a very technical approach. We teach it to our fourth-year undergraduates in the Department of Statistics. But I'm going to explain it with pictures, and I hope you'll more or less understand it. We take dengue incidents over 5 or 6 years. We split it up into two groups, a training set and a validation set. The training set is going to be bigger. It'll be about 90% and 10% validation. We compare lots of different models of varying complexity. And for each one, after we fit it, we see how well does it forecast that validation set. If the model is too complex over here, it won't forecast it well. If it's too simple, it won't forecast it well. But if it's at the Goldilocks spot, it will forecast it well. We try different combinations of the validation set and take an overall average of this and choose whichever has the best predictive performance. So here's the video. I could get into the slides. We've fit the data to 2006 to 2012, and we're forecasting into the current dengue outbreak. You'll notice that we're forecasting the upswing really quite accurately. To be honest, I'm a little bit surprised at how well we did there. And we're also forecasting the downswing fairly accurately for most of the time, like there. Let's go forward. Now, there's other approaches that you could use. We've compared it to a more traditional time series approach, seasonal, auto-regressive, integrated moving average. And ours is much more accurate. When we forecast into the future, we're getting maybe an average discrepancy of about 20 between the actual number of cases and the forecast number of cases, whereas traditional methods have they are really rubbish when you forecast into the future. Now, one of the main limitations which has surfaced since we started publicizing, the forecasts have been used by National Environment Agency, been used by Ministry of Health and by some of the hospitals. One of the main limitations that we've seen is that people say, oh, so why is it going up and why is it going down again? One of the problems is that we cannot really assess that because it's a bit of a black box. Essentially, we have a separate model for each forecast into the future, this way. And we're using our data sets at multiple lags into the past. So when I'm forecasting next week or 2 weeks or 3 weeks into the future, I'm using this week's temperature, last week's temperature, 2 weeks ago's temperature. And all of them can come into all of those models. So it becomes very difficult to disentangle what's the temperature effect. Here's some attempt to try to do so. Here we have a picture where we're going into the future here and into the past here. We are looking at the autoregressive term, i.e. past dengue. We find that it is useful to use the last 3 weeks worth of dengue to make any forecast into the future. These ones are all positively correlated. And it's useful to go back several months into the past, about half a year into the past in fact, because that tells you about, there's a negative correlation then. It's just saying that if it's high in the past, a long time ago, it should be lower going into the future. So here's it's relatively clear, but when we're looking at the breeding percentage, it is really very messy. This part here in red is negative. There's a strange negative relationship going back about 12 weeks, is it? For some reason there's a 12-week lag. I don't understand this yet. That's one of the difficulties with this approach. It really is a black box, and trying to extract meaning from it is difficult. We have various ongoing research projects. We're developing a spatio-temporal risk forecast, which uses some more geographic data, which may be of interest to the geographers here. We're also forecasting within clusters to help focus the control efforts onto those clusters which are more likely to grow bigger. So, who did this work? The work on pandemic flu was done by people at Tan Tock Seng Hospital, Faculty of Science, and School of Public Health, School of Medicine. The work with dengue is actually primarily done by EHI. National Environment Agency is funding the dengue research, although I'm funded by the Centre for Infectious Disease Epidemiology and Research in the School of Public Health. Thank you very much for your attention.